Good morning. We're using this because we're recording. I'm delighted to have all of you here. The opportunity to have this session came up rather suddenly, and so I'm delighted that you all were able to respond. Dr. Flaherty will be our speaker for the lecture on aging at noon, and he'll be talking about polypharmacy and adding some different perspectives from what he's going to do this morning. So love to have you come back if you are able to do that. Dr. Flaherty graduated from St. Louis University School of Medicine in 1990. He completed internal medicine residency at Kansas University, and he's from Kansas City area, and a geriatrics fellowship at St. Louis U. He's currently professor of internal medicine and geriatrics at St. Louis University, and a member of the faculty there who's very involved with geriatric scholars program education activities, and has been a real mentor for a lot of people, I think, in geriatrics in the St. Louis area and way beyond. He's co-director for the fellowship program for Division of Geriatrics at St. Louis U, co-director of palliative care consult service at the St. Louis U Hospital, and medical director for the ACE unit. And I hope you're going to talk about that just a little bit. Come on up and we'll get started, but delighted to welcome you and have you here with us this morning.
Okay. Well, thank you for inviting me, and thanks for coming, or else I wouldn't have an audience. I guess the people in Arizona are enjoying the weather, maybe. Let's see. So I've met a few of you, at least what disciplines you are and where you work. So as I go along, if you want to stop me, if you want to ask questions, we can make this informal. This topic was chosen for the people in Arizona who would be mostly medical students and physicians practicing in hospitals. But this may still apply for the mental health folks and the end of life. I guess it's also important because we're all involved in, whether it's our parents or we have friends who have parents and they're older and they get into the hospital and they get delirium or acute confusion. So I think everybody in healthcare needs to know about this and talk about it, because in medical school I didn't learn about it back in the late 80s. I only learned about it as time went. That's my disclosures. So I guess my emphasis when I talk about delirium is I try to get people to think about the brain. Okay. These people are not crazy when they're confused. It's a medical illness, and this is not such an old illness or syndrome. This was the first textbook ever devoted to delirium, and it's just 30-something years old. And so if you want to remember one kind of, what is delirium, think about brain failure. I like the word brain failure. All right. So whether it's one of us, and our brains are usually pretty high functioning, and then if we were to get delirium, let's say we were in a car accident and we were to hit our head really hard, or we were after a major surgery and we were confused after the surgery, that confusion is actually going on in the brain. That's brain failure. You'd like to think that the brain's going to bounce back, but not always, as I'll show you. So, cerebral functional decompensation due to a physical illness. That's kind of the definition. Now, why not use the word, there's one physician in the audience, I'll pick on him. I was taught to use the term acute change in mental status. You know that term? You see that a lot. Acute confusional state. But if you use this term and you go to search in the literature using Ovid or any of those search engines, you see you're not going to get any articles. The articles come under the term delirium. So get rid of those old terms of acute confusional state, acute mental status. The proper term is delirium. Delirium is delirium. Call it what it is. Now, believe it or not, we're seeing it everywhere. Here's palliative care, end of life. This is a burgeoning area of research now. We don't do very well. You can tell us what do we do at the end of life when someone's confused? Yeah, you give them, pound them with Haldol, pound them with Ativan, try to sedate them so they're not, pulling out, getting out of bed now. That's probably not the right thing to do, but we don't know what to do yet at the end of life. I can tell you what to do in medicine and surgery and the ICU, which I'll go into. There's a new area that's growing. It's pediatrics. I didn't put up the adults with developmental disability. There's a conference in St. Louis in May, big conference on developmental disability. I'll be talking at that. But that's an area that probably needs to be addressed in this realm of delirium. So it has hit the media. This story was about a retired professor, biochemist, really intelligent guy, got in the hospital with either a gallbladder or some kind of simple infection. And he started taking his clothes off and cussing at the nurses and all that. And the family, of course, completely distraught. This isn't our professor father. So you all know vital signs, right? Which vital sign is missing? Which organ? The brain, right? The brain. So we do everything we can, but everyone ignores the brain. So here's a proposal. We were proposing years ago, the sixth vital sign would be the brain, okay, the mental status. And here's maybe what it looks like. We're actually going to do a study this summer at St. Louis University Hospital. We're going to compare the nurses doing their vital signs plus this to the attending physician to say whether the patient's delirious or not, and see if a quick tool like this can pick up, normally primarily older people, but this could go for younger people. They might be in this range, but if they become this way or this way, something's happening. Now, what do we do in hospitals and nursing homes? If someone becomes a little bit like lethargic and drowsy, oh, it's just the medicines. They'll be all right. But remember, it could be a medical illness. End of life, we think, oh, it's just the medicines. Or they become agitated, well, maybe it's just their bowel and bladder. But we should be thinking delirium, delirium, delirium. And do we need to do something? Okay. Now, here's one of the diagnostic tools. I'm not going to go into this, but we do have ways of diagnosing delirium accurately, besides just saying, oh, they're confused. And this confusion assessment method's been very well studied, but I'll just point to two. Inattention. And so what I teach my medical students and residents is you have someone say, start with Saturday. Try this for me. Start with Saturday and say the days of the week backwards. Yeah. Well, we'll see.
Saturday, Friday, Thursday, Wednesday, Tuesday, Wednesday, Sunday.
Perfect. Now, it even works with people with dementia. And one of the key principles of delirium is not dementia, and dementia is not delirium. Now, you can get delirium on top of dementia. And as I'll show you, actually, people who get delirious very seriously, long term, they can higher risk to develop dementia because they're both in the brain. But if someone comes in the hospital, doctors take the easy way out and say, well, we don't know what their baseline is. Maybe this is the way they always are. Well, no, you should be able to do days of the week backwards. That's attention. And then level of consciousness, I think, is very key. I mean, right now you're alert. Hopefully, if you drop down to here during the lecture, don't worry. I won't get worried unless you're 3 or plus 3. But that's really key if someone's not alert. That's abnormal. So, very good tool. It's not real intuitive. You got to practice it a little bit, but as effective as a trained psychiatrist. So I put 3 objectives up here. We'll flip around a little bit, but I guess I'd like to emphasize the why question. Well, big deal. Again, I learned this as a medical student, even as a resident. I was told over and over by my attendings, if someone was in the ICU and confused, they said, we'll just get them better, we'll get them out of the ICU, and the confusion will get better. And then when they were on the floor, they'd say, let's just get the pneumonia better, the heart failure better, get them out of the hospital, and the confusion will get better. So, boy, I was bothered by that for years, and it finds out that no, you have to aggressively identify the delirium, treat it or manage it while you're treating the illnesses. So it is a big deal to prolong your delirium. The other thing is these drugs. We'll talk a little bit about these drugs used in delirium. And then how to manage patients. If I'm going to stop these drugs, we have to know how to manage delirium. or agitation, that stuff. I will mention that agitation does not equal delirium. Okay, so you have people with dementia and you have people with delirium. Both of those groups can get agitated for different reasons, and we'll talk a little bit about that. Okay, this is how common it is in the hospital, but it's not identified. And then here's some of the consequences. I'm just going to emphasize the mortality part and these other two things here. Long-term cognitive impairment, and there's even something called post-traumatic stress disorder related to delirium that's being studied now. But the big one, I think that these are all common sense, but people die because they're delirious. That's a serious illness. These are the studies comparing non-delirious to delirious, and they even control for underlying comorbidities and cognitive impairment. And you see the delirium group inevitably higher. Then you'd think, okay, get them out of the hospital to get better. But look at this, 6 months and 12 months later, still higher mortality. So what is going on? So here's a brain. This is an MRI of the brain. And if I told you this person, if I didn't tell you their age, what might you guess is their age? See how it's shrunken? Normally the brain should fill up the skull. We shouldn't have all that space in there. This person was in the ICU for a couple weeks. They had sepsis. Of course, they had delirium on top of everything else. And this person was only 49 years old, previously very functional. And after her hospital stay, she kept going to doctors after doctor saying, I just can't think as good. And they even tested her. They even did her IQ. And her IQ was 110, 118, and then she finally said, well, I had IQ before I got sick, IQ testing. Nobody does that. But for some reason she had. I think she was a professional in some certain area of business, and she really wanted to put that on her CV or resume. And so when people saw that, they were shocked. And one of the neuropsychologists at Vanderbilt took a keen interest in her, and they looked back and found all that. So what is happening when people are in the ICU with sepsis and delirium and the brain? Something's going on in the brain that we used to ignore. And unfortunately, we're still ignoring it. So finally, this came out in New England Journal of Medicine last October. And this group down in Vanderbilt looked at ICU patients, and they were able to figure out only 6% had cognitive impairment before they were in the ICU. 74% developed delirium while they're in, and that's pretty common. Anywhere from 50 to 80% of ICU patients get delirious. Again, people say, oh, it's the ICU, don't worry, get them out, they'll be fine, turn the lights on, let them sleep. Well, that's good. But what happens if they're delirious? Well, it turns out that the delirious patients, this R-bands is basically, it's kind of a neuropsychology test, and it tells you where your brain is functioning. So it's a pretty good psychological test, memory test, things like that. So look at these people. The greater than 65 group, their average R-bands score falls below this mild cognitive impairment line. It even falls in this area of traumatic brain injury and Alzheimer's disease. So these people are really taking some hits. But even the younger group, see, this is the norm. These people, after they come out of the ICU 3 months and 12 months later, there's some people that bounce back to normal, but the mean, so something is happening in the ICU. Don't ever put me in the ICU. You know, I'm wondering. So, and then what this is trying to show is that the more days of delirium, okay, you get out here to 5. After 5, it's kind of all the same. But if we were to catch delirium early, day 1, day 2, we might be able to save some brain, I guess is how you could think about it. Mm-hmm. I won't go into this. This just tells you people criticize because, well, it's all the medicines they use in the ICU. But they controlled for that part, and it's not the medicines causing this. Like the anesthesia. Post-op, after the surgery, people always blame delirium on the anesthesia. It's not the anesthesia. After about 12 hours, that stuff should be out of your system. So if someone's delirious the day after surgery, something else is going on. Something else is going on. And then here's the pictorial for post-traumatic stress disorder. This was this person who drew it, this is what they were thinking about while they were in the ICU. You can imagine how bad it's. And there's videos on YouTube that people are talking about their experience. It's pretty dramatic. Not everybody remembers being in the ICU, which is good, and not everybody remembers being on the ventilator. But there are some stories where people really remember. I mean, anything, well, I felt I was being raped. I felt there was a chain up and down my throat. Just terrible stories. All right, now this is the hard part. I'm going to show, if you know what this term is, it doesn't even spell right in spell check. The neuropathophysiology. In other words, what's going on in the brain when someone is delirious? So the next slide is probably the worst slide you've ever seen. So you can shade your eyes if you want. But this is what's going on in the brain when someone's delirious. So if you know anything about neurochemicals, neurotransmitters, and oxygen to the brain, you may have heard about norepinephrine, dopamine in the brain. You guys know about dopamine, serotonin, what other? Adrenergic activity, and then there's the oxygen. So all this stuff plays together. So what happens is when someone's delirious, these chemicals in the brain are fluctuating. We don't know what's high, what's low. We think the primary problem is dopamine in acetylcholine. All right. So then we think, okay, if someone's delirious, let's see, they've got these things going on. Here's our drugs. So what's the most common group of drugs used for delirium are the antipsychotics. Same with agitated behavior, behavioral with dementia, things like that. And here are the receptors. So I know none of us are pharmacologists, but if you think about high blood pressure pills, they hit 1 or 2 receptors. So a common heart pill, Coreg, carvedilol, or metoprolol, one of the beta blockers, there's like 2 beta receptors that those drugs hit, beta 1 and beta 2. And that's a pretty simple drug. I give it to you, and it stops your beta 1, beta 2. All right, lowers your blood pressure, lowers your heart rate. So here's a drug I'm going to give you. I'm going to give you Seroquel. Now there's 1, 2, 3, 4, 5, 6, 7 receptors in your brain that this drug is affecting. It's almost like a 60s psychedelic drug. You know, you don't know what you're going to get. Olanzapine's notorious. You give someone that drug, and you're never quite sure what you're going to get. Okay? Dopamine, or a Haldol, is pretty good to start with because it only hits 4 receptors. And in schizophrenia, we know the problem is an imbalance of dopamine. So you give someone Haldol, and it balances that out. So now someone's delirious, and you pick a drug, and now you guys will get this because you're outside big cities. People don't understand what a shotgun is. I gave this talk in Poland last week, and I guess I don't know what a shotgun is, but you know what it shoots like this. So the doctor given the drug, that's what I feel like. When I give Seroquel or olanzapine to a patient, I'm just kind of throwing it in their system, getting it to their brain, and hoping it hits the right receptors. That's not right. And this is why your stories of, you know, my son was like this after so many drugs, you don't know what you're going to expect. Okay. So there is a better way. This just goes into more what's going on in the brain. We looked at all the studies we could, myself and 2 people, Dr. Dong from China and Dr. Gonzalez from somewhere on the East Coast. He's a pharmacist. And so we actually did our own systematic review, and we basically found some interesting results. Many of the studies didn't have a control group. Okay? So they were taking patients who were delirious, they were trying a drug, and lo and behold, the drug made people better by day 2 to 3, day 4 to 7. Oh my gosh, they're better. It must be the drug. Right? That's not right. A first-year med student would know, wait a minute, you got to compare it to something else, like a placebo. So none of these studies had placebo in them. None of these had placebo except one. One study so far of medical surgical patients has done a placebo. And how about this one? Well, it's the only study that had no difference in either group after day 1, day 3, day 5. So you're like, golly. So maybe the drug's not making them better, it just makes the nurses feel better. And it gets people through those few days of delirium. So as far as we know, these drugs at this point, there's no evidence that we should be using them. In fact, none of them are FDA approved for treatment of delirium. So if you're seeing them used in hospital patients for delirium, the doctor is using them out of the FDA allowance. Okay. Now, it doesn't mean they might not work, but we need more studies. But this is what I was taught. Use Haldol. Someone's confused, give them Haldol. There are a couple studies, prophylaxis in non-cardiac surgery. Non-cardiac surgery, this is out of Beijing, China. And then this one is out of the Netherlands. And there were some positives. So giving people very tiny doses of Haldol during surgery, let's see, continuous infusion. Yep, all the way through the intensive care unit. So there might be some hope there. Not a very good study. This study showed hip surgery patients, most of them were elective. They got placebo, which was good, versus Haldol. There was no difference in post-op delirium after major hip surgery. They did find that the scores were a little better, the DRS, delirium rating score. But, you know, give me a break, I guess I should say. I'm a little biased here. 4 points on a 45-point scale, not a big difference to me. Clinically, that wouldn't make a big difference. So the bottom line is it really did make a difference in the percent of people who got delirious after surgery. We were involved at St. Louis University in this trial. We won't have results for at least 6 more months. They've closed the trial now, coming up in June. What it is there's the sites they're all looking at. They take people undergoing surgery, and the reason I point this up is if it shows a positive, you might start seeing patients going to surgery get this drug. They're comparing dexmedetomidine to placebo, and you start it right during pre-op, and then through the operation, and then 1 to 2 hours after the surgery in the recovery room. All right? And we'll see at 3 and 6 months if these people are any better. Have a gut feeling it's not going to show much of a difference, unfortunately. Now, there are studies out there that are being done or will be done. Here's a placebo-controlled trial. Here's another placebo. Northeastern University, a couple Canada. So again, people are trying to do these studies. A couple more in the Netherlands, Indiana, Vanderbilt. So the jury is right now for the use of antipsychotics like Haldol or Seroquel to treat delirium. There's no strong evidence to do it, and it's non-FDA approved. That's the 2 take-home messages right now. So what do you do if you can't use the drugs to calm people down? Have to develop something. Well, I'm going to focus on 2 areas, medical patients and ICU patients. First thing is if someone gets confused in the hospital or maybe at home. I'll throw these in there for you guys. Because if you have someone at home and they've been okay for a while and all of a sudden they become delirious, think about this list of problems. And for the end-of-life patients, I'll emphasize a few here. One is if there was any new drug that was started recently. And I've seen simple drugs. I've seen naproxen cause just a little bit of confusion in a frail older person. They just didn't feel right. You stop it and they got better. I've seen metoprolol, beta blockers, simple blood pressure pills cause confusion. So you have to just be suspicious about any medicine. The worst I've ever seen was eye drops. Eye drops. And I never would have believed it. It's been reported in the literature. And then I was on call one night, and one of my colleagues' patients called. It was the son, and says, oh, my mom is just confused. I said, anything new going on? Has she been sick? Oh, she went to the eye doctor yesterday and got some new eye drops. And I'm like, Oh, there's no way. I said, okay, just stop the eye drops and call us tomorrow if she's not better. And sure enough, she got better. But she was very frail. So think about people who get delirious. They're very frail usually. The brain is not normally working. So people with developmental disabilities are at high risk to get confusion on top of their normal baseline. Same people with dementia. High risk. The brain's not working normally already. And so why would, if, for example, UTI, we all know, okay, urinary tract infection can make people sick and maybe cause some confusion or delirium. Now, everybody here, if we were to get a UTI, we'd feel uncomfortable. But what is it about that person that the brain is not working correctly already? They get infection. Something about the infection goes to the brain and causes confusion. Okay? So that's where that infection part comes. But don't over-treat the UTI. What I commonly see in our hospital is an older person will come from the nursing home for delirium. We'll send them in because we can't figure it out. We'll send them in. They'll look at them. They'll get the urinalysis and say, oh, UTI, and they'll put them in with antibiotics. Well, you have to look harder because sometimes the infection they have is not the urinary tract. It could be an abscess somewhere. It could be a tooth abscess. It could be gallbladder disease. It could be diverticulitis. So in a delirious patient, how are you going to get the exam? It's hard. So you have to step back and watch the delirious patient, see if they give you clues. All right, so that's the infection. Drugs, I'll give you a list of drugs here in a minute. I don't necessarily, again, at the end of life, I try to get the hospice nurses I work with, and you're probably good at this, don't check the pulse ox. All right, good, I see it. Don't do that. That just makes people panic. What's more important than the pulse oximeter is the respiratory rate. Does the respiratory rate look comfortable? Because in itself, low oxygen itself probably doesn't cause delirium. But stroke, which could be a hypoxic insult to the brain, you can get confused. You can get delirium. Same with PE. I've seen pulmonary embolus cause delirium. I've seen MI cause delirium. Now, I don't know the mechanisms, but it's not strictly just a low oxygen on the pulse ox. Now, what about, let's see, there's some of the drugs. You can go to this article that we reviewed a bunch of case reports, and we even found antibiotics could cause confusion. Muscle relaxers are notorious. Don't use muscle relaxers in the elderly. The last time I did, I was an intern in Kansas City, and my grandmother had fallen. She broke her pelvis, and she was at the rehab and came home. And when she got home, she was walking with the walker, and she developed a stiff neck. So unfortunately, I'd had my MD training, so all I knew was, okay, stiff neck, give her a pill. Gave her a muscle relaxer, and the only thing she remembered 3 days later was that I had given her the pill. I mean, she was just so confused. My grandfather was all upset at me. That was the last muscle relaxer I ordered in the past 23 years. So, of course, insomnia drugs, you can kind of look at these. All right, now here's this could be at end of life. Someone's been in the hospital for 4 or 5 days. Let's just change this to an 84-year-old man with heart failure. Instead of feeling better after 3 or 4 days, the family says, oh, he's end of life, we're ready to take him home. So they send him home with hospice, and the first day he's home, or the next day, you guys see him, and he's agitated. Now you have to think back, what did they do in the hospital for 3 or 4 days because of heart failure and I's and O's? What do they put in old people when they want input-output? Catheter. So they wanted to do it because they felt sorry for him. They wanted to keep him comfortable. And then when they discharged him home, oh, yeah, let's take the catheter out. He gets home. He's been home for about 12 hours. Now what's he got? Retention, right. And there's a technical term for this, cystobladder cerebral syndrome. It's delirium associated with urinary retention. Now you see this all the time in the hospital too, because people don't get out of bed, or they put the catheter in, then they pull it out. So I used to actually wear a button that said it had no Foley, and the word Foley and then a red cross through it. We probably should almost never use Foley catheters. Once in a while at the end of life, but in general, try to avoid them. Okay. But this is very treatable. You straight cath and the bladder relaxes and the brain relaxes. People get better. Cystocerebral syndrome. Okay. Look for that. Let me go back. ICTO refers to seizures. Once in a while, you'll pick up that a person is confused off and on during the day, but they won't have the complete tonic-clonic seizure. They might just have a partial seizure. And about half of seizures in the elderly are partial seizures. They're not the full-blown tonic-clonic. So you might miss the shaking of the arm or the leg, and then they're just post-ictal for a while. And they wake up, they're okay, and they do it again, and then they're post-ictal. But to the family, everybody sees them as just confused all day. So I'm just be aware of that. Underhydration, if the brain isn't hydrated, it's not going to work as well. There's actually a movement in hospice for end-of-life delirium, and I haven't jumped on the bandwagon yet, but to give those people IV fluids. Now, at the end of life, I know IV fluids is a bad idea because people can't tolerate them sometimes. They cause more edema, more respiratory problems. So just be aware that that might be coming down the road. I need to see some studies that if they're dying, they're doing okay, they're calm, and then right towards the end of life, they get real confused, and confusion can be very uncomfortable, as we talked about, for the family and the patient. Could giving them a day or two of IV fluids without prolonging their life, or without causing more pain, I hope, could it clear the delirium so that they die not confused? So just food for thought there. Of course, metabolic and then subdural. We'll go over those. Okay. Oh, no, so in hospitals now, how do you prevent delirium? If I tell you you can't give drugs to treat delirium, and maybe the ones that we use don't prevent delirium, are there non-pharmacological ways? And this might have to do, if people live in facilities or group homes, this might come into play on how to prevent some of this. So what these researchers did was they looked at patients in the hospital with any of these risk factors. So think about your residents in a group home or in a nursing home or primarily the hospital. Do any of the patients have baseline dementia, eye and ear problems, sleep-wake problems, dehydration problems? Are there 3 or more new medicines? Did they restrict their mobility recently? If you have any of that, then yes, you're high risk. Then you get this. So the researchers in the hospital randomized patients to usual care or getting a good protocol for sleep, pushing fluids. Now this is all common sense stuff, but even in the study where they had research nurses, they didn't get to 100%. But good geriatric units, good geriatric care in the hospital should do all of this for their patients. Now, of these, to prevent delirium, which one do you think is most important if you had to pick one? Fluids. That's the one I thought when I talked to the researcher. I said, if you keep people hydrated. But turned out it was the ambulation. So that, again, that was the researcher's opinion of how they got the results. Here are the results. They cut delirium by 30%. To me, that's huge. All right. It wasn't very high in either group, but I think even the usual care group in the same hospital was getting some of the interventions because it was one hospital. So nurses on this floor were telling the nurses, hey, get people out of bed, it helps. But they reduced delirium quite remarkably. All right. And that's their website. If you just Googled help or the Hospital Elder Life Program, Dr. Inouye is the researcher. She's doing great things in delirium prevention. Here's our 2 models. We don't have as much research money, but we developed this room called the Delirium Room, which was low cost. And we published 2 reports. We call our room you can call it the close observation room, the delirium room. But the key components is there's no restraints, no physical restraints, and there's always a nurse type person in there, always, whether it's a nurse aide or an RN or LPN. All right, 24-hour nursing. Here's what it looks like. There's 4 beds, 1 bed here, 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 and then the nurse has a desk probably about here, so the nurse can do his or her work. And if the patients are climbing out of bed, they can go over there and see what's going on. They can help them. You see, we use commodes, we use curtains. So we do mix men and women. That's a little bit of a criticism, but once the family, most of the time families know that, hey, there's going to be a nurse watching, they're like, oh, that's better than down the hall. If you ever come to St. Louis, I'll take you for a little tour, 2-minute tour. The one at DePere Hospital is 4 beds straight across, so it's a little easier to keep privacy. All right. And what we showed is that length of stay in the delirious versus non-delirious, the expected and actual length of stay was the same. And typically, if you remember, length of stay is always longer in delirious patients than non-delirious. So we were pretty happy that we kept length of stay the same. Mortality, although it was lower, it was a small study. So I wouldn't say delirium rooms can prevent mortality yet, or reduce mortality, but it's safe. They were not killing each other in there. Now, we are a teaching university, so residents are who's writing the orders. So even with residents who like to order medicines at an MD program, only 1/4 of the patients got some form of medication for delirium. In the literature, it's about 50 to 70% in hospitalized patients get some kind of drug. This is the research from DePere Hospital, our community hospital, a little larger group. What we found is that the delirious patients came in with a lower ADL, so they came in with lower function, but they gained function before they left, which is pretty unheard of in hospitalized patients. Normally people come out of the hospital, they're worse than when they went in, before they got sick. So we were happy about that. Again, that was part of just getting them out of bed constantly, and there's just more numbers here. This has been replicated. The Delirium Room has been replicated now in Singapore. Hong Kong is getting one, and this is New Zealand, and then somewhere in Europe. But unfortunately, Americans haven't kind of jumped on this bandwagon, so I don't know of any other delirium rooms around the country. Now, what do we do? So you can't just put a nurse in there and say, watch this. So these are your 4 delirious patients. I just can't take you and say, here, don't let those people fall, take care of them. So this is our approach. It's called the Tadam Method. Tada. So this is, I'm not a nurse, but I learned a ton from the nurses. And this is what they've taught me over 20 years, is when someone is getting out of bed, you let them, right? But what do most hospitals do? Most hospital nurses, if someone's getting out of bed, get back in bed. Well, I don't want to get back. I want out. Well, you can't. And then they start getting this, and that's the don't agitate part. Okay? So this is very, very hard. I'm not saying it's easy. And then the anticipate part is what happens when people are delirious in the hospital? They pull on stuff, right? So you have to, you know that's going to happen. So don't get mad at them when they do it. That's our fault. So a couple methods is you put the IV in, and then you put a decoy IV. Now you don't put the decoy in, you just tape it around there and let it dangle. So the confused person sees something dangling and they start pulling on it. That's natural, that's human nature. The good IV is all wrapped up, it's hidden, and then when you need it, you use it. And so instead of giving continuous IV fluids, you give boluses. Boluses. How often do you come in the room and the IV is hanging there right in front of the confused person, and you see this wire, and of course they're pulling at it because they're confused. Same with tubes. If you have to have a DOP-off or an NG tube in, you don't just let it hang out the front here. You kind of wrap it around back if you can. Try to avoid restraints. And we all know physical restraints cause agitation. Months ago, I came in the hospital on a weekend for a consult, my fellow and I, and the consult was for an older man who had had a hip fracture a month ago, was at rehab, came back, went to another rehab, and came back because they thought he had seizures, and he was on the neurology service for about a week, and they did every test known to man. MRI, LP, EEG. They did everything. And they call us and said, you know, he's still very confused, and the nursing home won't take him back. Can you come help us? That was the consult. So I said, oh, okay. So I go in there, and despite everything being negative, they still had him in bed the whole week. They had those seizure precaution pillows on the side. And I said, I thought there was no seizure. Yeah, but, well, we didn't take those off. Yeah, okay. So there's 2 restraints right there. They had those SCDs on his legs. There's 2 more. They had a Foley catheter in. They had 2 wrist restraints. That's 4, 5, 6. They had the IV. They had the oxygen. And they had a DOP-off tube. So I guess that's 9 different tethers and restraints. So wow. So the wife was there, fortunately. And so I knew this was going to take a while, but this is our geriatric intervention for this situation, is we started taking those off. We undid the easy one was the seizure precautions, took those away, put the bed rails down. The nurse was watching. I had to explain, I said, well, I'm going to try this. I'll be here. I'm going to do this the whole time. And the nurse was like, are you sure? The nurse was very nervous that I was going to unleash this guy. Because he was confused. He was pulling on stuff. He was in and out of consciousness. You know, he was very, very delirious. So I did that, took off the things on his legs, the SCDs. Then the big ones, I took off his wrist restraints. As soon as I did that, he started doing this and pulling on stuff. He's like, oh, he's going to move. And I said, that's okay. Unhooked the IV, took the oxygen off. So the only thing remaining was the DOP off, and I let that hang. And then the big move was we were sit him on the side of the bed. And he hadn't done that in 5, 6 days. So I got him to the side of the bed, legs hanging, my fellows helping me, and he kind of perks up a little bit just sitting on the side of the bed. And the wife's like, "Whoa, he looks better." I said, "Okay." I look at my fellow, and my fellow breaks a sweat by now. I said, "Are you ready?" And the fellow thought we were finished. I said, "No, we have to get him to the chair." And the fellow just looks pale. I said, "Come on, he was a big guy, big farmer." And so we were able to muscle him over to the chair, and he flops in the chair, and he's sitting up. He's like, "Wow, good, okay." And his eyes open a little bit. And so just cutting off all that stuff and getting him out of bed immediately started clearing the cloud that was over his brain. Now, what happened is that every day I came in, we had to do it again and again, but by day 3 or 4, he was ready for discharge, and we were able to discharge him to a facility for rehab. But this is hard. So if you go back to your facilities or your folks, and you go into a hospital and your parents in the hospital, your grandparents in the hospital, and you tell the nurses, "Hey, I had this lecture, you don't tie my grandmother down, you need to get her out of bed," we know the response. Right? But what you can tell them is it's doable. It's doable. People are doing it around the country. I'll show you. I think Josh put this up on. So this website is a little PR, little advertisement here. The American Delirium Society. We're about 4 or 5 years old. It's a group of primarily geriatricians, but we have pediatricians now. We have intensivists. And our next meeting is in June. But this is our relatively new website. And here's a couple videos under resources. If you go under resources down to videos. And this video in particular is for hospital. You might be more interested in this one. Maybe I'll show a little bit this since you all have people in facilities. Let me.
What do you want, Mrs. Williams?
My lunch.
This is her.
So we hired actors and actresses, and we taught them how to be agitated. And this really isn't delirium. This is just kind of behavioral issues in the nursing facility. And so what we're demonstrating here is what can happen when you do the wrong things. People become easily agitated. You can't cope if you have dementia. So let's watch these 3 ladies. That's the nurse back there. Is that okay?
Her lunch.
Help me. My lunch. Help me.
I'll get your lunch. Just wait here.
Don't touch me. I want to eat now.
I'll get your lunch. What would you like?
Let's stop Okay. So I'm not going to go through this, but, you know, the nurse kind of came over and touched her right away, tried to resolve it right away. They didn't anticipate, didn't tolerate, kind of agitated. So let's watch a few. Let's see.
Diffuse the situation. Let's see if this works.
Hello, Mrs. Williams. Are you ready for lunch?
So see, a good nurse knows her residents. And they know that she's hovering for some reason. Boom, early intervention, distraction.
Hungry. My lunch. Time to eat lunch.
Mrs.
Hungry, my lunch. So what is she actually saying? My lunch. Her lunch, what? My lunch. Yeah. Yeah, but why does she think that's hers? Because this is a facility. This lady's been in there for about 3 or 4 years. She just moved in a week or 2 ago. And where she sits, that's right. My lunch, she has dementia, she can't get all the words out. This is my lunch place. This is where I eat lunch every day for 3 years or however long, she doesn't know. So watch how cool the nurse does
Johnson, this is Mrs. Williams. Could I ask you to move over to this chair?
Oh, I'm sitting here.
Well, I know. If I could ask you to move over to this chair, it'll be your chair.
Well, I sat here first.
I know that this chair is Mrs. Williams. It's very important to her. This chair, if you will, be yours, and Mrs. Williams can sit in hers, and we can all have lunch.
My lunch.
I'll get you lunch.
Not everybody's happy, so let's see if there's another solution. Watch, this is a little.
Mrs. Williams, are you ready for lunch?
Hungry. Time for lunch.
Mrs. Johnson? This is Mrs. Williams.
See how she lifts her up?
Mrs. Williams has
Makes her
been
stand
with
up.
us for over a year. You two are
Hi.
going to have lunch together today.
Slyly moves it over there. So again, I think some of the take-home messages I've learned over the years from nurses is we try to reason in logic with our residents and our patient, and you can't sometimes. And not that you want to trick them, but you can use distraction techniques to get everybody to be on the same page. So she's like, oh, come on over, sit here, and we'll have a good time. And everybody's happy. All right. That helps families too, because families are the biggest group that try to reason and logic with these people with cognitive impairment. Okay, let's see if I can get out of here. The hospital one, I won't show you that. It shows, I'll just explain it. It shows a person all agitated, older guy, because he's got the Foley catheter. And the nurse comes and says, hey, what are you doing? He's like, get this. She's just like, you don't be messing with that. You're going to hurt yourself. Well, he doesn't know that. Okay, he's confused. Take this, and gets more and more agitated the more time she gets agitated. So the next scene is her, she's coming in, and he said, what's wrong, Mr. Jones? This. Oh, I see the problem. He gives a big sigh of relief. I see the problem. It is a problem. Well, let's try to move this. And then she calls another nurse in to kind of distract him and just talk to him while she goes and gets the order from the physician to pull the Foley catheter out. And then everybody's happy. So those are some methods to, if you want to say, the madness to all this. Now, ICU, if we have 5 minutes, I'm only going to show you that the ICU now is one of the biggest areas for delirium management and delirium prevention. And the hallmark of ICU patients, people on the ventilator, they're sedated. Once in a while, people can be awake and have the ventilator, the tube down their throat, and they can breathe. But in general, people are sedated because it's uncomfortable, which is good, right? But the standard is we should wake them up every day and see if they can breathe on their own. In the old days, I'll ask our physician too, when I went through ICU training as a resident, what'd they teach us? You would look at a person on the ventilator, and you'd say, well, no, they're not ready to come off yet. Let's wait another day. And you check an x-ray, you check their white count. Let's wait one more day. They might be able to do it. So there was no method. The method is every day, stop all the sedation, wake up, and breathe. If they can do it, good, you're going to take them off that day. If they can't, you put the sedation back up, and they go down and they rest for another day. But you got to get people moving. Let's see if I got this. So the Wake Up and Breathe trial, the cool thing is, in the hospital, compared to usual care, there was no difference. But again, it's that 1 year out. 1 year out, a few weeks, and it stays. That's where you see the difference in mortality. You don't see it while they're in the ICU. It doesn't change that much. But those people you get off the ventilator, prevent the delirium, and then this is the most amazing thing that's happening now. Look, this is an ICU guy. This is a real guy. ICU, you see he's on the ventilator. He's got the tube. He's got the Foley catheter, unfortunately. He's got drips, and these are the two therapists. So these two therapists, oh, here we go, studied this randomized controlled trial, usual care, control group versus intervention, and I'll just give you the bottom line here. The bottom line was out of bed within 1 to 2 days in the intervention group, on the ventilator. All these patients were on the ventilator. A lot of them had drips and all that stuff, getting them out of bed. And the results, I think, speak for themselves. 2 days of delirium instead of 4. And functional recovery, 59% versus 35%. So, God forbid my mother would ever be in the ICU, but if my mother's in the ICU, I'm getting her out of the bed day 1, because if she's in this group, there's a better chance she's going to have to come live with me because she'll be dysfunctional. But if she's in this group, she'll have a better chance getting back to her function. Okay? Now again, I warn the ICU folks, you don't see any of this positive stuff while they're in the ICU. After they get out of the ICU, that's when you start to see better function. So ICU nurses look at this and they think we're crazy. We're not going to make a difference getting these people out of bed. Let's see if I have one more video and then we'll close it up from there. This is pretty amazing, just to prove to you.
Within intensive care medicine, we've gotten better at helping patients understand the consequences. These patients understand the consequences.
See that lady? Oh, there she is. See this lady? So that's an elderly lady, tubes, drips, all this stuff. Let's see if we can see if she's walking here. Here we go. Here we go.
We know that one of the worst things we can do probably is to leave someone in.
Every time I see that video, I'm amazed. This is a frail older woman. Not frail, I guess. Maybe she's got some meat to her, which is good. All right. So I will flip through these to the end. Future of delirium is we better have better drugs, better target drugs, and then we'll have more education from around the country. So, okay. All right, there's St. Louis. So, thanks very much for your attention. Yeah, any questions?
So if they're not able to get out of bed by themselves, like able to get up and stand and walk, transferring them to the chair, even if it's...
Yes. And going for the highest level that they've achieved before they got sick. And so, again, really applies to palliative care. You've had the longer, if you've ever been sick, the longer you stay in bed, you really start to feel uncomfortable. And I know families are like, well, don't get them out of bed. It's so hard on them. But you got to at least try. At the least, sit them on the side of the bed with their legs hanging. At the least. And let them see if, and don't be afraid, they're not going to hurt themselves. If they fall and they're sitting in bed, they'll fall back in the bed. And especially if they're trying to get out of bed on their own, what we teach our nurses in the delirium room is if someone's, I'll imitate it here, if this is the bed and you're the nurse, that nurse can see me this far away, I'm going to try to get out of bed. But I remember I'm sick, I'm confused, so what I might do is I might start doing this, and as I do this, I'm wearing myself out. This may go on for 10 or 15 minutes. But if you come over, the minute you come over and say, don't get out of bed, I'm going to fight you. So let the person do this. Now, if I get this far, then you come and you stand next to me or close by. Again, close without interrupting. And you're like, okay, don't say anything. That's our TLC gene. Don't say anything and don't touch them. Let them struggle a little bit. And if they get too far, then come over here, just put a hand out. Again, I teach my residents and students when we're going around with a large group of people and there's someone with dementia or delirium, only one person talks in the room. Only one person. Because if more than one person is talking and a confused person, just escalates. So no talking is even better. Put your hand out. Naturally, people will see it. They might get to this far. And if they get this far, sometimes if they get this far, I put the belt on real quick. So I've got a little safety belt. And if they get this far, great. Now, that's 20 minutes we just did, but that's 20 minutes of therapy. That's some good stuff. So, all right. Any other thoughts or questions? I mean, I'll say what I said to my group last week at a conference, because they kept asking me, well, how much Haldol do you use? What's the dose? Because they were pushing me. I said, when you have to use a drug, this is what I use and this is the dose. And at the end I said, if you give me time, you give me that 1 hour, 95% of patients, I won't have to use a drug, at least while I'm there. Now, when I'm gone after that hour and nighttime comes and the night nurse comes or something, you know, I can't be there. But if the nurse could do what I'm doing, again, 95% of the time, I've never had to use a drug to help an agitated person. Okay, yeah.
Kind of bring it up when you're thinking of the delirium is coming from all these restrictions. Basically, I mean, that's really what we're seeing the reason why in the ICU. I mean, because restrictions, all the tubes, all the everything.
We think it's, so now it's just, I'm going to give you my opinion and based on their opinion. We think all the restrictions and the tubes are prolonging that delirium.
Okay.
And I think of the example where I took all that stuff off the guy. He was still delirious after he sat up and got into the chair, but the severity was much less.
Okay.
See, in the bed and the restraints and all those restricted mobility things, he was in this fog. We kind of just lifted the fog. His underlying problem for the delirium still had to be fixed. And I think it was just the fact that some of the medicines we kind of tapered off eventually, and then whatever he had causing it kind of let it clear faster.
It's being caused by some kind of physical thing that's going on in your body that you have to find.
Yes, that's the first principle. Find out the medical reason for the delirium. But while you're doing it, don't make it worse and prolong it. And I think that's what the ICU people do. That's what you do by stop all that sedation, let people wake up, cut the delirium days. Yeah. It's hard. It's hard, but okay. All right. Well, thank you. Thank you very much.